CREST syndrome, also known as the limited cutaneous form of systemic sclerosis, is a multisystem connective tissue disorder. The acronym CREST refers to the 5 main features: calcinosis, Raynaud's phenomenon, esophageal dysmotility, sclerodactyly and telangiectasia. It is associated with detectable antibodies against centromeres, and usually spares the kidneys. If the lungs are involved, it is usually in the form of pulmonary arterial hypertension. Signs and symptoms: calcinosis, CREST lcSSc causes thickening and tightening of the skin with deposition of calcific nodules. Raynaud's phenomenon. Raynaud's phenomenon is frequently the first manifestation of CREST lcSSc, preceding other symptoms by years. Stress and cold temperature induces an exaggerated vasoconstriction of the small arteries, arterioles, and thermoregulatory vessels of the skin of the digits. Clinically, this manifests as a white-blue-red transitions in skin color. Underlying this transition is pallor and cyanosis of the digits, followed by a reactive hyperemia as they rheum. In contrast to uncomplicated primary Raynaud phenomenon, this occurrence is often painful. Frequently this phenomenon leads to digital ulcerations, gangrene, or amputation. Ulceration can predispose to chronic infections of the involved site. Esophageal dysmotility presents as a sensation of food getting stuck in the mid or lower esophagus, atypical chest pain, or cough. Patients often state they must drink liquids to swallow solid food. This motility problem results from atrophy of the gastrointestinal tract wall smooth muscle. This change may occur with or without pathologic evidence of significant tissue fibrosis. Sclerodactyly, though it is the most easily recognizable manifestation, it is not prominent in all patients. Thickening generally only involves the skin of the fingers distal to the metacarpophalangeal joints in CREST. Early in the course of the disease, the skin may appear edematous and inflamed. Eventually, dermal fibroblasts overproduce extracellular matrix leading to increased tissue collage deposition in the skin. Collagen cross-linking then causes a progressive skin tightening. Digital ischemic ulcers commonly form on the distal fingers in 30 to 50% of patients. Telangiectasias, marked telangiectasias occur on the skin of the face, the palmar surface of the hands, and the mucous membranes. Telangiectasias tend to be more numerous in those patients with other scleroderma-related vascular disease. The number of telangiectasias in the sites involved tend to increase over time. Other symptoms of CREST syndrome can be exhaustion, weakness, difficulties with breathing, dizziness and badly healing wounds. Patients with lcSSc commonly induce pulmonary artery hypertension which may result in pulmonary. Etiology: CREST syndrome involves the production of autoimmune antinuclear and anticentromere antibodies, though their etiology is not currently understood. There is no known infectious cause. Treatment: disease progression may be slowed with immunosuppressives and other medications, and esophageal reflux, pulmonary hypertension and Raynaud phenomenon may benefit from symptomatic treatment. However, there is no cure for this disease as there is no cure for scleroderma in general. Epidemiology: CREST syndrome can be noted in up to 10% of patients with primary biliary cirrhosis. History: the combination of symptoms was first reported in 1964 by R.H. Interbourne, at that point a medical student at Johns Hopkins School of Medicine. See also, scleroderma, references.